Good morning and welcome. I'm David Collins, Senior Director of mHealth, and proud to be your moderator for this morning's session, Driving an mHealth Strategy, Clinical Intelligence, and Industry Perspectives. This session will provide cross-industry perspectives on crafting an mHealth care setting. Topics will range from strategic direction to implementing or improving workflow and measuring success. So let me give you an idea of the flow of the 75 minutes. 75 minutes seems like a long time, but believe it or not, it goes quickly. So each presenter will present for about 12 minutes. They each have a slide deck, and then we're going to open it up for 1 or 2 questions, and then we'll move to the next presenter. At the end, we'll have open Q&A for another 5 or 10 minutes. And there's another session, of course, coming in this room, so when you want to come up and get autographs and things like that, we'll move it to the hallway. So Joyce Lignell, Vice President ARW, will be presenting first, and we'll be covering real-time data sharing and behavior change. James Gaston, Senior Director with HIMSS Analytics, will touch on technology to monitor cardiac failure, such as weight and other factors. Yael Harris with HRSA, Director of HRSA, is going to give an overview of the Text for Tots program, its inception, sampling a message pilot, and next steps. Donato Tremutive, Founder and Chair of Healthy Villages, is going to give you a snapshot into their 10 pilots that they have in motion and how they are training clinicians to best use your technology in the practice setting. So, as each presenter gets up, they're going to give you a snapshot of who they are, just a brief bio, and definitely encourage you to write down some questions as you're listening to take advantage of that opportunity for 1 or 2 questions in between speakers. So, that's how we're going to learn and have a dynamic, interesting session. So, Joyce, thank you.
Good morning. I'm Joyce Lignell with Applied Research Works, and I've been with the company for about 2 years. Prior to that, I was a chief innovator with Blue Cross Blue Shield in the state of Hawaii. So I think over the last 3 days, we've all heard over and over again, and maybe even if you've attended this conference or even any others, you've heard that throughout the industry, great change is upon us throughout healthcare. And this often is what it feels like. Specific to the state of Hawaii, where I'm going to talk about a particular case study for today's purposes, these are all the things they're dealing with right now. And I take a moment to sort of highlight this because it really impacts and pertains to everything I'm going to talk to you about today. So the overarching driver for all of this, of course, and I think this is true for everybody in this room probably at some level, is cost sustainability, achieving that cost sustainability. With that, health plans have really focused on, or at least specific to Blue Cross Blue Shield in Hawaii, they've really just made a firm commitment to deploying new payment models. With new payment models, which includes things like pay for performance and shared savings, comes new care delivery models. So embedded into that are PCMHs that are being formed, ACOs that are being formed. All of these things are new, and they're happening at different levels, and there's a lot of churning as they all kind of come to terms with the change that's impacting them internally. With those changes comes great dependency upon quality and defining the term quality and, of course, quality outcomes. And with that comes standards. So then you hear terms like NCQA and HEDIS, PQA, STARS for the Medicare program, NQF, MSSP if you're an ACO. Many of these terms are out there, and these are standards that are also having to be put in place at the same time. Well, with that comes dependency, great dependency upon engagement. The need for all of these things to succeed really depends on getting that patient engaged. And so I'm really going to try to focus in on that specific area, particular for today. So the Hawaii rollout, Applied Research Works has gone in and deployed an infrastructure across the state of Hawaii for Blue Cross Blue Shield. So this includes, of course, the health plan themselves, all of their members, so all of their PCPs, and I do call out the PCPs specifically. That's taken place throughout the year 2012. Next year, they'll be deploying out to the specialty realm. HMSAs, physician organizations, and probably most innovatively, but I'm not going to speak about it much today, is their partners. So they even include their case management company that they've brought in. They've included their PBM, CVS, in very, very specific ways, and all of this is wrapped around also engagement. So it's very, very interesting what's happening there. This is not a pilot. So in many presentations that I've listened to over the last several days, they've all been based around pilots. And in fact, we did start out as a pilot. In November 2011, we came in as an engagement platform, and we were asked to demonstrate the viability of an engagement platform. So what sits on top of it is deploying all of the pay-for-quality goals out to the doctors. And then from there, the doctors can immediately engage through that same platform, act on those measures, and engage with their patients. And we proved that in one IPA, or physician organization, on the Big Island of Hawaii that encompassed 16 different doctors and about, I want to say, 10,000 members or patients. When we started at the end of November, most of the quality measures that we rolled out to doctors were somewhere, we have what we call the chiclets. And the chiclets are red, yellow, green. It tells the doctors where they stand in any one of the particular measures. And there are about 20 measures we rolled out from the health plan. And they were in some stage of orange, we'll say, red or yellow mostly, a little bit of green here and there. That was at the end of 2011. They had till the end of the calendar year 2012 to achieve green, if you will, in those measures in order to achieve their payment on those quality measures. By December 31st, every one of those 16 doctors were almost completely green. And the way they were able to do that was through that dynamic dashboard and engaging with their patients, they were able to prove that they could meet their goals in real time using this tool. So immediately HMSA made the decision to roll out in 2012 to their entire provider network. So again, it's not a pilot. It encompasses about 700 PCPs. The membership in Hawaii for Blue Cross Blue Shield is somewhere around 700,000. And there's about 20 different physician organizations spread across the islands. So you're all wondering, what is that? Well, what did you really do? So these are the numbers. Right now we have onboarded about 620 PCPs. Now, let me just say something about that. I'm going to try and keep my time quick here. Doctors don't want a new tool. They don't want another dashboard. They don't want another application sitting in front of them. There was a huge amount of resistance, especially when we went into the pilot on the Big Island. Those doctors are incredibly savvy at delaying, putting us off. It was phenomenal. And when we finally got in there and were able to demonstrate what this could do, within the first week they held a physician organization meeting, and their dashboards are protected and for their eyes only. It's not like every other doctor can see how they're performing. They went into this physician organization meeting and shared, they're competitive. They are type A personalities. And they all wanted green, and they all wanted to be number one, and they all wanted to, it became a game, and so what ended up happening is as they went out to other physician organization meetings throughout the state of Hawaii on behalf of Blue Cross Blue Shield, they started spreading the word that this tool could help them make their money and pay for quality, and we had a waiting list. So we have onboarded these 620 doctors in the space of about 6 months, and we have our track shoes on, trying to keep up with them. We only have, that's an important number right there, membership, only 5,500. Those are mostly on the Big Island. There's a process that occurs. It's important to mHealth here that we're going to talk about here in just a minute. That's where we're going to focus. And then about 10 POs are using the tool. When HMSA, Blue Cross Blue Shield, came into this about 3 years ago as they were planning this entire deployment, they really saw as pay for quality was emerging, as PCMHs were emerging, all these models were kind of out there, and they were trying to figure out how do they get to the nut of deploying all these things simultaneously. They really decided that all things would support the physician-patient relationship, everything. Everything that was deployed, everything that was done had to make that relationship work optimally in order for all goals to be achieved. So our job to be done, what we were handed to do, was first of all to deploy the engagement platform that hosted these pay-for-quality measures. And then we had to train the doctors, the POs, and really advocate on behalf of the patient on how to transform and become quality-driven. And there's really, this is different. That's not to say all clinicians, all practices aren't already quality organizations. They are. It's the definition of quality and what does pay for quality mean, and how to really move into more of a proactive, preventive mode along with all the other typical care that's being delivered on a daily basis. There is some transformation that has to occur to encompass all of that. There has to be action on the goals, and it's not just on the part of the doctor, because really the truth is the doctor's not really the one using this tool, it's the staff. The staff really gets engaged, it really becomes a game for them, they use it as a pre-planning tool, and then it's them advocating and us helping to advocate on behalf of getting those patients to actually register on the tool. But the most important thing about COSIVA, and I think this is something that needs to be thought of widespread throughout all of mHealth and any kind of engagement tool, is that not every patient is engaged. Those that are actually going to register, they're engaged. They want to participate. They want to be interactive on their care. So you need a system that can also push out to those who are not engaged. So really what this system does, what COSIVA does, is it takes in all of the practices already standing contact information. So if there's a phone number for me, Joyce Lignell, and I've not yet registered on COSIVA and I'm a disengaged patient, this system can call out to me on that phone number and treat me, and it uses the doctor's phone number, so I see it coming in. It feels just like the standard process that's always occurred. But if I were registered on COSIVA, I could use it on my smartphone, I could get text messages, I get to choose how I want to be engaged. So it can go either way. And then finally, it gets down to measuring and reporting. But the real beauty of doing this on a real-time platform with engagement engine underneath is it does happen in real time. So as patients are acting and as practices are actively executing on these measures, you can see things happening in real time. You can see information changing. Purpose-driven engagement, that's what I call it, because there's a purpose to this. The doctors are engaged in it because they need to be and they want to be. Their staff is engaged in it because they need to be and they want to be. And patients are engaged in it because doctors are reaching out to them in proactive ways, telling them, you know, you need a mammogram, you're due for this or you're due for that, in new and different ways. But it's not easy, and some of the challenges that we've experienced, and I don't know if some of you may have also experienced some of these, is I already talked about the first one, really, or maybe I haven't so much. The truth is, when we first came to doctors with COSIVA and talked about engagement, doctors are like, whoa. I have my own secure messaging, I have my own tools, I don't need another tool, I don't need this. But it's important for them to understand that how they engage with a patient is important to track and to do it in a way that meets also their quality goals. These things have to kind of bundle together. Managing how to contact a patient is hard work. So getting them to engage and then keeping that contact information updated and keeping that patient interactive in the system it's work. And so part of what the tool does is it really kind of shifts the load off the practice and really puts it onto COSIVA, the tool. Robust engagement requires new processes. This one is important. I've heard through several sessions the question come up about, well, what's keeping engagement from happening in a more robust manner? And I think the real answer here is one of the reasons why clinicians, doctors, or practices push back on engagement isn't because they don't want to. It's because they know, and I now know firsthand, this impacts their workflow. It's not as bad as they think it's going to be, but it is going to change how they interact with the patient. It is going to change the workload and the response for, how am I doing on time? Okay. It's going to change how it impacts their practice. And so you have to plan ahead. You need to create processes and expect a new kind of workflow and interaction to occur within your practice and build for that. Developing compelling interfaces for the users. Okay, this is important, and this really rests on the shoulders of the vendor. And healthcare has a tendency, due to regulatory reasons, HIPAA, lots of things drive why we end up with such a dry, stale application. There's security that has to be there, and it's some people. Consumers forget their passwords, and we need really tough ones because we got to protect their data. But there's a lot of things competing for a consumer's attention or a patient's attention. And so how do we build an app that's very compelling and keeps that user? Once you get them, how do you keep them engaged? One of the most important things is that there's you on the other side. You're listening, you're responding, you're actually paying attention to them. When they engage in that app and they talk to you, there needs to be somebody on the other end.
Great. Great, thank you very much. I hate to cut you off, but we're going to have to keep running. I feel like I'm talking to half the audience here. Oh, there's other people back there. Great. Any Q&A? We'll take one or two questions from the audience, and then, of course, we'll have more questions at the end of the oral session. I did have one question. In terms of how you set the quality measures, what was the plan? What quality measures did you select, and what were your measures of success?
So the real driver for measures was driven by HMSA's rolling out of a Medicare Advantage plan. So within Medicare Advantage, there's a program called STARS, which really helps to rate the health plan so that you as a consumer can choose between different Medicare plans based on how highly rated they are. So the measures that we deployed on behalf of Blue Cross Blue Shield were within that framework.
And measures of success?
Measures of success are quite literally, there's a numerator and a denominator that really speaks to how many people fall within. Let's just, for example, talk about breast cancer measure. There's maybe a total number on the pan on that particular registry, and then of them, how many of them are compliant. And you literally track through this engagement platform who's acting or not acting on those measures.
And then it was interesting how you said the patient can actually choose how they engage. So is there an opt-in, opt-out, or is it not that simple? Yes.
There's opt-in, opt-out, and then if you're participating, you can certainly set up how you wish to be contacted. And if it's, let's say it's text message, we do have what we call pre and post messaging so that as it goes out in text message, it's all HIPAA compliant and really just letting you know there's a more sensitive message available for you in another location. So,
excellent. Thank you again. And now we'll hear from James Gaston, Arkansas Blue Cross Blue Shield, and we'll hear about their technology to monitor cardiac failure. And James is with HIMSS Analytics as Senior Director.
Good morning, folks. All right, I'm going to try a trifecta of technology. So we're going to start the fancy Spaceship Enterprise timer, so I won't run over. We're going to use the laptop because I have to read the speaker notes, right, while I present, or else I'll just be really winging it. And then we're going to use mobile technology here to advance the slides and move the slides around, which probably could be a risk. Right. All right. Hey, good morning. James Gaston. Work for HIMSS Analytics in clinical and business intelligence, and I worked for a decade in makes me old, for Arkansas Blue Cross Blue Shield. Had some buddies over there who were doing some work with mobile technology. So let me tell you a little bit about HIMSS Analytics. See, advance the slide. HIMSS Analytics is a not-for-profit subsidiary of HIMSS, which probably some of you all are familiar with. Collect and analyze healthcare information related to IT processes, environments, products, IS departments, etc. Arkansas Blue Cross Blue Shield was founded in 1948, is an independent licensee of the Blue Cross Blue Shield Association. We have a little bit of a blue theme going on here. I didn't realize you were going to be engaged with the Blue Plan in Hawaii, which I've never visited. That would be a nice one to visit. And they have about 2,800 employees. All right. Oops, did I see? Come on now. All right, cardiac heart failure. So Arkansas Blue Cross Blue Shield has a program with their company called Advanced Connected Health that helps monitor heart failure patients. So heart failure is often called congestive heart failure or cardiac failure, occurs when the heart is unable to provide sufficient pump action. That's from Wikipedia, to distribute blood flow to meet the needs of the body. Heart failure can cause a number of symptoms, including shortness of breath, leg swelling, exercise intolerance, and common causes include myocardial infarction. These are from my hospital days. I can pronounce some of these things. Ischemic heart disease, hypertension, valvular heart disease, and cardiomyopathy. Any of you all experiencing any of that in the audience today? Raise your hands. I know a few of you probably are. No? All right. So that was, as you can appreciate, an insurer's significant concern. They created the Arkansas Connected Health Program to develop some solutions to address these problems, which can be expensive and to the detriment of their member population. So ACH, as it's called, created a pilot wireless remote telemonitoring program for fully insured members with cardiac heart failure, or CHF. It was clinically coordinated the program to utilize weight gain in CHF patients and other early indicators to identify those that were having problems. One of the unique things about this program, it's not just about the technology, it's really about the processes behind the program that engage the patients, the physicians, and the physicians' office staff. So these advanced practice nurses collaborate with the cardiologists in the state and individuals with CHF who experience unanticipated weight gain or have blood pressure problems or other medication problems, and intervene when they have agreed upon coordinated clinical protocols. So it's not just the insurance company deciding when these advanced nurse practitioners engage or talk to them, or they decide on their own. They actually have protocol that the physicians that are participating in the program have worked up with the nurses, and it drives some standardization of specific guidelines around how people are engaged. So this provides a cost-effective, eyes-on approach that is currently absent in our marketplace. The value proposition is by reducing the time between symptom onset and intervention, the program reduces hospital readmissions by 50%. Currently, these patients are seeing a 34% readmission rate in other late-stage costs. 34% readmission rate in Arkansas with this Blue Plan. That's not very good. So, and there's certainly other costs and lingering health concerns and deterioration caused by CHF. All right. So what are they doing actually? So they have these wireless devices. I think you can go see the Ideal Life wireless products out on the vendor floor at this event, which is pretty neat to actually see them in person and all the different things that you can connect to the Ideal Life pod, which collects the information and then sends it back into the personal health record at Arkansas Blue Cross Blue Shield, which is also populated with the patient claim data. All right. And the personal health record is the location, the central repository of the information that's collected from out in the field in the patient's home And that way it's available to the patient, it's available to the nurse practitioners, and it can be available to the physicians in their offices. All right. There we go. Technology is working. So, selection and enrollment. Potential enrollees are identified from the claims data. Physician can refer identified enrollees. Hospitals can refer newly diagnosed patients into the program. The physician writes a script, just like they would any other script, submits an order for enrollment, and the advanced nurse practitioners verify the critical data and the clinical data and enroll the member via a phone call. Once the member is enrolled, their weight and their blood pressure are checked every morning. Alerts are triggered by these built-in protocols that we mentioned a minute ago in these algorithms, so they're automatically, the nurses are automatically notified if there's an issue. The calls are made to the members that have alerts, and the staff initiate a phone assessment. Now, one of the unique things about using an advanced nurse practitioner, they can look at the patient as a whole. So they're not just limited to, well, your blood pressure's high or your weight's high, and I'm going to tell somebody else what's going on. They can actually assess the patient, their medications, their environmental factors, and consider things other than their cardiology or cardiac condition at that point, which is what happens. And they can adjust those medications because nurse practitioners have the ability to do that without necessarily bothering the patient's physician. Now, certainly they notify the patient's physician whenever there's an adjustment to the medications, but they don't necessarily have to engage that physician prior to working that through with the patient. Okay. Go here. And go here. All right, so patient satisfaction from the program. They've did a satisfaction survey, and you can see it scored very well. They improved care coordination, patient compliance with prescribed medications, discovery and treatment of potentially serious conditions, and improved patient engagement in managing their condition, which is something we would all like to do with all our patients. Result to date, it's too early to gauge with real specific accuracy, but their goal is to reduce 30 and 90-day readmission rates and ER visits, which is happening. Care gap reduction is also occurring. So Arkansas Connected Health has developed this pilot. It's going very well. Oh, you know what? I went the wrong way on this one. See, the technology is overwhelming here. I apologize. Okay, so I wanted to tell you real quick in my minute 30 seconds left before it turns yellow. So case 1, patient was referred for CHF monitoring, telemonitoring, by the cardiologist. During the first week of telemonitoring, the patient was hospitalized for chest pain. So that would be a bad thing. That would be going back to the hospital. After hospitalization, the GI referral was recommended since the patient reportedly had normal cardiac cath and performance. The Arkansas Center for Connected Health coordinated the appointment with the GI physician and the testing to rule out issues of cardiac disease. They discovered the patient wasn't taking the prescribed medications, so they actually sit down, talk with the patient about their medications, and work through those medications, which was LASIK, and the experienced weight gain and elevated blood pressure were a result of that. So, it's something as simple as that, as talking with the patient. Are you actually taking your medicine? It's critical, and that's where these nurse practitioners have more time to engage the patient in a meaningful way, find out some of the issues. So once the patient became compliant with their medications, their blood pressure and weight came down and came to goal. More patient education was identified, and the patient was taking other medications inappropriately. So, educated the patient. Patient started back, that is really distracting, on their regular scheduled dose of LASIK and some potassium, and was ordered to included with that medication. And then, of course, they followed up with lab to ensure the kidney function was proper and potassium remained stable, and the medications were adjusted over time. A cardiologist was informed of all medication changes and the laboratory results, and they were able to address complaints of insomnia and daytime drowsiness. So, by having the nurse practitioners there, using the mobile technology as a way to build an alert system that is coordinated with physician oversight and nurse oversight, the Arkansas Center for Connected Health was able to engage patients, provide them patient education, and ensure they got the right care at the right time to address those needs and reduce hospital readmissions. They're well on their way to achieving their goal. Now I can blink red. All right.
Very good. Thank you, sir. Plenty of seats up front. Please come up to the microphone as their session is recorded. You have a question?
Pauline Balch, Kaiser Permanente. And the first two, I'm just unclear, what was mobile about the program?
Well, I think what's mobile about the program is the Ideal Life technology that enables the patient to be anywhere in the state, basically, and have their blood pressure and their weight tracked and monitored on a daily basis or more frequently, and then uploaded into the personal health record at the Blue Plan.
Okay.
And Joyce?
Well, we also had a mobile component, so the engagement that takes place with all the patients can be done across the mobile platform. So if you have a mobile phone, we can push out to that.
So it's text, it's pushing
Anything.
text or email?
Email, text,
phone calls, IVR?
Smartphone application, yeah.
Okay.
Yeah.
And did you use IVR in the CHF program at all? Voice response, automated voice response?
Yeah. No. The nurse practitioners engage patients personally.
Okay. Thanks.
Thank you.
Good question. Thank you.
How was this financed? Like, who paid for it? Was the
With
Blue Plan?
money.
Yeah.
The Blue Plan. So the Blue Plan created this venture, Connected Health. Was it Arkansas Connected Health? I'm trying to remember. Oh, see, I've got to use technology here. Yeah. Arkansas Center for Connected Health is a spin-off or a organization that would engage patients in a meaningful way around their health. What we found, and maybe you can corroborate, is that when you approach patients and say, we're from your insurance company and we're here to help you monitor your health, you get a little bit of a negative response. And so by taking the Blue name out of it and the insurance company stigma out of the name, they found that people were much more easy to engage. So money was put into this organization to build up and trial and build out this program.
Did the doctors receive an incentive for participating?
No.
Oh, okay.
So the incentive, and that was one of the tricky parts. So you actually had to pester some of the cardiologists and say, look, you're already busy. You have patients that are at risk and need more attention than you and your staff can allocate to them. This is a way for you to expand the bandwidth of your practice and the performance of your practice. And that's how they were approached and sold to them. We didn't want to have the nurse practitioners call and leave a voicemail message like anybody else can do at their practice and wait for someone to get back to them at the end of the day. Part of the agreement was that when Arkansas Connected Health called their practice, they would talk to a lead person there who could immediately coordinate with the physician or the lead at that practice. So that's what keeps it quick and tight and timely.
Thanks.
You're welcome.
And I'm sorry, we probably have to move on to our next speaker. If you could hold your question. I thank you. And now we'll have E.L. Harris, Dr. Harris, Director of HRSA, and she'll address the Text for Tots program.
Thanks so much.
Oh, you might need that.
Oh, all right. Rings forward. Maybe not. Wait, we're way out of order, but did I go too fast? There we go. Okay. So, hi, everyone. I'm Yael Harris. I'm not the director of the Health Resources and Services Administration. Thanks so much, though. I'm just the director of the Office of Health, IT, and Quality, but I really appreciate the job promotion, and I'm sure my boss doesn't. In any case, people don't know what we are. The Health Resources and Services Administration is not MRSA. Someone just asked me if we're an infectious disease yesterday, and I thought that was pretty creative. We actually are the part of HHS that provides safety net services, so working with federally qualified health centers, rural health clinics, critical access hospitals, Ryan White clinics. And this project actually has nothing to do with any of those. It's more the population in general. And what this came out of was a real need for how do we deal with the growing obesity problem in America, and how can we leverage existing mobile technology to really help address that problem. And so basically, as you know, pediatric obesity is a huge problem in America, significant healthcare costs later in life, especially when you talk about low-income and minority populations. If anyone saw the movie Escape Fire, there's a whole discussion about why are hamburgers at McDonald's 39 cents and get to buy fresh fruit for your children is $5 bushel. And then I've got a 4-year-old, so anyone can empathize. He wants that cheeseburger. It's really hard. He does not want those strawberries. He won't eat any fresh fruit. So, there's limited parent information. We're really busy, and I have 2 jobs, but only 2 jobs. I don't work 3 jobs at different shifts. I have a car. I can get to my job. I'm not taking buses. So really, how do you get the information you need in time that works for you? Until kids start school, there really is no source of regular information, especially if you don't have a regular health care provider. And there's really no information on how to encourage healthy eating. We're bombarded by information on the television about McDonald's having McDonald's, the price of their cheeseburgers, about unhealthy activities that kids could engage in, like, playing Moshi Monsters on TV. If anyone's got a pre-adolescent daughter, that's her favorite thing. So these are not activities that they're fine for moderate, but we want our kids to be engaging in more physical activities. There's no information about there's a scavenger hunt going on this weekend, or, how do you what can you do outside to be active and engage, especially if you're in an urban inner city environment. And then there's this Text for Baby program. If anyone doesn't know about it, come see me afterwards. But Text for Baby is a huge program reaching hundreds of thousands of moms across America and caregivers. How do we leverage this population? Because they're aging out at age 1. Their kids, when they turn age 1, don't get these messages. And yet they're finding value in this. So how do we reach out to them and get them information that they need until their kids enter a school system where hopefully they're getting some guidance from the school nutritionist, from the school counselor, they're getting regular meals at school. So skipping this, basically just to let you know, we started in the summer of 2011 thinking through how do we work with this. Right now we're in department clearance. I'll talk more about that. So the project design was basically, my agency has a grant with the American Academy of Pediatrics, a cooperative agreement. So it's kind of a grant with a little more requirements. What we did was we said, you developed the Bright Futures Guidelines. Many people who are in pediatrics know what those are. Those are well-established guidelines for all types of healthcare activities for children ages newborn through age 18, and we said, could we look at those related to nutrition and physical activity and develop text messages, so, less than 160 characters, for a population of caregivers, whether it's pediatricians, parents, school care providers, daycare providers, around healthy eating and nutrition. And so we worked with them to do so, and part of that was, could we develop focus groups to look at, would this be valuable? And so this picture shows you we worked in focus groups across the nation, and we asked them questions about, first of all, like going back to the other slide, would this be valuable? Would you do this? And then after we develop messages, how would you use this? Would you be likely to receive these messages? How could we tweak them to better meet your needs? And so we used focus group demographics. We got a group of English-speaking patients and a group of Spanish-speaking patients. And as you can see, we got quite a diverse population. Our focus, as you understand, being the safety net provider, was on looking at populations that are uninsured or underinsured. So looking at those that are high on public insurance, assuming, not being biased, but assuming that they have less time on their hands to find the information that they need to provide their kids healthy information. So how do we get that information in their hands? And we spoke to them. Almost all the groups really felt that text messaging was an easy vehicle. They're all very familiar with, or most of them are very familiar with it. There's no problems with it. They don't worry about privacy and security if the messages are generic enough. And we asked them, where do you get reliable health information? Now, a majority of them said primary health care providers, but a majority of them didn't even have a regular source of health care. So who is that regular primary health care provider? They're not seeing that patient on a regular basis. So it could be the pediatrician they're seeing in the ER or at the clinic. I'm just as guilty. Whenever my kids are sick, I work full time. I go to the 24-hour or the 12-hour, nighttime pediatric clinic. It's a little more expensive than my primary care doctor, but I don't have the time to take off from work, drive an hour to where I live from my office, sit in the doctor's office, and I'm sure these parents are even in even more financial straits than I am. I love the now get your child immunized at night thing. It works in my schedule. It's better. I'm willing to pay extra for it. These moms don't have that vehicle of taking time off to get to that source of information they need. So they need information in real time, whether it's a social service agency, they can call it a 1-800 number, the internet, information that they can access. And also to know about internet, most people have a mobile phone. And this is something I've been talking about all over this conversation, all over this conference. If you're talking about a homeless population or you're talking about someone who's low income, they may not have an internet connection at home, especially when you're talking rural areas. But almost all of them have a cell phone. And almost all of them can get access to the internet on their smartphone. More than 50% now have a smartphone. So that's really a great source of information. But about 98% of the nation has a phone. So even if they don't have an internet access on their smartphone, they can get text messaging. It's a matter of finding them and getting them the information they need relevant to where they are at their stage in life. So looking at the focus group, the things that really shocked me about this group is 8% of these kids. Now these are focus groups of parents with kids aged 1 through 5. We're not talking teenagers. We're not talking even preteens. We're talking children ages 1 through 5, preschool age. 8% don't have breakfast daily. 25% consume sugary beverages every single day. 31% have a television in their bedroom, and about average, they watch 2 hours of TV every single day. The other thing that really shocked me was as a parent of young children, I can't guarantee what my kids are eating. For breakfast, they're not eating fresh fruits and vegetables. Let me be honest. If I can get 2 waffles or a bowl of oatmeal in them, I'm calling it a successful day and we're on our way. Lunchtime, I know my 4-year-old is throwing his lunch away because when he's brought home a sandwich without a bite in it, I yell at him. So saying, why didn't you eat your lunch but you ate your, baked Cheetos? So now he doesn't tell me, he just throws it away. So I know I'm not getting healthy food and vegetables into him whatsoever during the day. Nighttime is the only time I can ensure that he's eating a balanced meal. And if only half the families are actually eating dinner together, they don't even know what their kids are eating at that meal. So the feedback we got from parents was basically that this would be valuable, that they like texting, but they need the information brief, they need it relevant, and they want 1 to 2 text messages a week. They don't want to be inundated with messages. And they really want information that's relevant, like when it's relevant for their child to get a screening, information about growth and development, and links to additional resources. So you guys can read this faster than I can, even though I'm from New York and talk very fast. But as you can see, parents did think this might be a valuable resource. We also met with providers, so nurse practitioners, clinicians, even caregivers. And what they said was that they would actually be willing to recommend this information for the patients they see, that they thought this would be useful information, this is something that they would trust because it came from the American Academy of Pediatrics, it's based on scientific evidence, and they could see value in this. So what we did was we developed a library of messages, 1 message per week. It could come out whenever the parents or caregiver wants it. So you could program it to come out if they want it in the morning on their way to work. It could come out Sundays when they're trying to get ready for the work week. It would include messages related to all these topics we talked about, and it would be available in English and Spanish. So here's just an example of some of those messages, topics, for you to look at, again, English and Spanish. So where do we go with this? And this is the gist of what I want to talk about. We had talked about, do we develop an app? But there's so many apps out there, and not everyone finds these apps. So the question is, and also some of these apps cost money. Not that I have any problem with people taking an app, developing it, charging money for it. If you can build it in, some of the ideas I had was linking it to local pharmacies and supermarkets that are having discounts on fruits, looking at to local community centers that were having physical activities on the weekends for kids, such as, a scavenger hunt or a bike ride, things that you could really encourage the kids to get out and do things with. That's great. But how do we make sure that this information is available for free to the communities that need it most? And how do we build it into existing programs that exist? Why would we create yet another app that someone needs to find on Haptik and download? Could we build it into existing networks? Are parents using existing resources that this could be a message that taps into them? Could Text Your Baby moms be told about this and be, asked, do you want to subscribe? So what I'm here to do today and we can do this afterwards, is if anyone has ideas, is interested, we would love to talk more about what ideas are out there and how do we move forward on this. So that's our real goal, is we're the federal government, we're not into making money off of this, but if I just post it on healthdata.gov, how many of you know what healthdata.gov even is? So it's about a third. That's great. That's the government's resource to get out information to the public. So if you want to go there, it's a great resource in that it's transparent, but not everyone even knows about it, and it's just inundated with data. So how do you even navigate what you're looking for there? We need to find a way that we can get this information to everyone who might be interested in using it and get people to start using it, get them to think creatively. How do we build on this? How do we fit into existing models? Could we link it to supermarkets that could do promotions when they're having fresh fruit sales? That's our goal, is really what opportunities are out there. So how can we do that? And we're looking to you guys to tell us how to do that. Because we have no problem making the messages free, but we want to make sure the messages are used and that they're moving people forward to giving them the information they need when and where they need them. So that'll take questions.
Hi, my name is Doug Nigley. I'm with a firm called Untitled Health. We built the technology behind smoke-free text 2 years ago, which of course now has a public library for smoking cessation messages, much like you have. And I wanted to ask, actually, could I ask you to go back to the slide with the timeline? I think it's 5 slides ago, or maybe 6 slides ago.
Getting there, I promise.
Yeah.
There you go.
Is there, do you think going through that process, there's a way to shorten that timeline up? I mean, we're talking almost a year and a half, right, from prioritized message concepts to almost launch, right? Have you seen, and this isn't a comment on your program, but in the future, have you seen choke points or areas where you think in 2013 and 14 and 15 there's a way to firm up that timeline and get things going quicker? Of course, knowing you're the federal government, I grant all
but
that.
I don't want to get fired. I mean, it's the government is not a dynamic organization, and I don't say that criticizing my organization. It's just that, a lot of this innovation needs to come from outside because the government can't move quickly for a number of reasons, good and bad. So, yeah, I definitely think, some of this stuff could have been, done. I think the focus group testing, it was, there were 2 stages of it, so that took longer. I'm trying to get a dynamic sample, but I think, but also, who we're working with, what we're working on. It's not a topic that and it's low-income families. It's not a topic that people are like, oh, I want to get involved,
Sure. Sure.
And then the government clearance process is long and arduous.
Yeah.
Again, to have that government stamp of approval, the American Academy of Pediatrics developed this, et cetera, requires that. That doesn't mean private sector couldn't develop something with physician input that could go much faster.
Yeah, interesting. Okay, thank you.
Thanks. And by the way, Eric Augustin has been one of our key advisors, so he's great.
Look at that, promoted and fired all in one presentation.
I wanted to speak to his point. One of the problems right now, I think, is socializing the idea of mobile, which requires clinicians to distill some of these key messages that they give all the time in the clinic. So it's not just the government. I mean, medicine itself is not a rapidly changing profession. But as I think you establish libraries of these helpful tips, you can translate them to other conditions. And as physicians become more comfortable, some of the tips from working with those conditions can be also extracted. So I just not want to dump on the government totally on this one.
Well, thanks. Absolutely. And that's why we did not just parent focus groups, but we've tried to work with, trying to get to my email address, but everyone saw it, right? But the goal is really how do we get this information into the hands of those who are trusted, reliable sources. They were saying, insurance comes and says, I want to help you. Let me tell you, when the government says, I want to help you, people go running. So we really want this to be seen as something initiated by the patients and supported by the doctors, and it's a trust relationship. So the government thought this would be a valuable resource, but it's not us promoting this. This needs to come organically from patients who need this information and from doctors who say this is a great way to get the information to my clients, because if I give them a pamphlet, they're going to lose it, or they may not even have a regular source of information. So how do I make sure that they know what types of activities and eating they could be telling their kids to do? And as an educated consumer, this information is useful for me. I would find it valuable to get a reminder saying, have you thought about doing a scavenger hunt through the house on a rainy day, so that my kids are not watching Disney Channel all day long. Trust me, that's a big challenge as a mom. So these kind of tips and ideas are really useful for any type of parent.
Just one quick question. I noticed in one of your slides there's a difference in the comfort level of texting between the English-speaking and the Spanish-speaking population. Didn't know if you had any feedback there.
You know, that's actually quite interesting because when you look at the use of text messaging in Pew studies, et cetera, it's actually higher among Spanish-speaking families. So this was a surprising result, and I don't know if it was a facet of our focus groups. Obviously, they weren't random. They were random samples, but they weren't, necessarily perfectly random. But we don't know. I mean, our major message was that more than half were very comfortable with text messaging. But I agree that all the studies I've looked at have said that in the Latino group, mobile phone usage is even higher. Comfort with using the cell phone is even higher. So I don't know what caused this discrepancy, but I do think if they get an average of 5 text messages per day, even in the Spanish group, that I think we should be fairly confident that 1 message per week would be very well received.
Absolutely.
Thanks.
Great. Thank you again. Okay, thank you very much. Our last presenter, Donato Tremuto, founder and chair of Healthy Villages. And if you've noticed what we've done here, we've gone kind of from a micro perspective to a macro perspective. So it's kind of built upon more of a regional program to a little bit broader with a payer, to even broader with HRSA, and now you're going to see global. So this should be very interesting.
Thank you, David, and fellow panelists. As the last speaker, I'm feeling kind of the same sensation I felt in 2006 when I ran for my first term in the state of Maine, and my campaign manager said to me, "You have one disadvantage. Your last name begins with the letter T, and you'll be the last person on the ballot, and you're going to lose votes." So I hope I don't lose the interest here today. By the way, I did win the election. I am very pleased to be here today. By way of background, I am also the founder, CEO, and vice chairman of Physicians Interactive, which is our commercial arm in providing, via the web and the mobile, clinical resources at the point of care to help physicians get engaged to provide services to patients. However, I am the founder of Healthy Villages. I want to first thank my co-founder, Carrie Kennedy, the president of the Robert F. Kennedy Center for Justice and Human Rights, of which I am honored to be on their leadership council and on the board in Europe. The Healthy Villages program started 2 years ago when Carrie and I were having dinner, and she was heading off to Haiti after the earthquake. And we were talking about ways that we could potentially help her be the ambassador to advance healthcare programs in Haiti. And I had this crazy idea of presenting her with a few of our mobile devices that would be preloaded with medical content that she could, in fact, bring to Haiti. And during that trip, in her capacity as the ambassador of the RFK Center, Carrie was writing to me and acknowledging lives were being saved, that clinicians for the first time were not guessing about dosaging, drug dosaging. They were actually using our RX dosage calculator and prescribing the right dosaging for patients. And so when she returned, I asked her, what are we going to do about this in terms of making this a global program? And so I'm really pleased to be here with you today to say that Healthy Villages was launched 1.5 years ago, and we are fulfilling our vision of empowering clinicians anywhere in the world with mobile devices that can help to enhance the delivery of healthcare. You've heard from my fellow panelists today more about mHealth strategies. If I were, in fact, representing my organization, Physicians Interactive, I would tailgate off of what they have done in terms of their great delivery. I'm here today, though, to focus in on what Healthy Villages is doing in the practical world. One of my panelists had mentioned about the accessibility of mobile phones. I was in India a few months ago, and I was really moved by the reality that out of 1.2 billion people living in India, 600 million do not have toilets. 50% of the population do not have toilets, but 60% have mobile phones. Figure that out. And so when people challenge me and they raise the question, what are you doing with Healthy Villages? You will never move that population in terms of using their phones for mobile health. I say you are wrong, and I hope today that we can demonstrate this to all of you. Many people ask how I entered into the field of healthcare. Sadly, I share with you a story that I very much hope will never happen to another family. More than 33 years ago, my sister-in-law went into a hospital to deliver what should have been a great moment in her life and my brother's life, and that was the birth of their second child. My sister-in-law died in childbirth. As a result of a medication error that could have been prevented then, should be prevented today, yet we know of many, many stories where these types of situations occur. And that's what has been my passion, to move, if we can, the needle toward a better delivery of health care that guarantees the full right that every single patient has a safe environment for health care delivery. The other night, I was honored at the Robert F. Kennedy annual celebration in New York to sit next to Taylor Swift. And so I think I am empowered to use this line. I will never, 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 ever, ever, ever say that mobile health does not save a life. Let me show you what I mean. Please show the video.
within just a few hours, I was able to replicate the information that we already learned. I was able to put that into practice, not only just in terms of what I've learned here for my benefit and in terms of continuous medical experience, but also in terms of helping that needy child.
No matter how many times I watch that video, I get chills. It's a true story, and one that I am pleased to say is being replicated every single day. How do we do this? Healthy Villages, through the commercial arm of my organization, we are downloading iPads and iPhones and making them very, very specific to the communities that we are launching these programs in. We have 6 pilots now in play. But let me just give you the evolution. I had shared with you that we launched Healthy Villages last year at the Health 2.0 conference. To date, we have 6 pilots across the world. We have handed out 59 devices and trained more than 80 clinicians. And these devices go from a academic center in Kenya. Dr. Mark Newton has pleaded with us About a year and a half ago, he shared with me that it's not only the difficulty of getting students to enter into the medical programs, the textbooks that they have are 60, 70, 80 years old, and there's only a few of them for the students. What we do now is we repurpose the medical textbooks and make them available on the mobile. They're current, they're up to date. The outcome there that we believe will occur is a much more elevated level of care delivery. To a situation in Uganda, in Achuma, where the Lord Coney destroyed that entire village and killed thousands and thousands of people, that we have partnered with Angels of Hope to develop a medical clinic in that community, but they didn't have funds to develop a maternity ward. And so Healthy Villages, through the association with the RFK Center, we petitioned pharmaceutical companies to help build out the maternity ward, and we have now provided the iPads and the mobile devices so that the clinicians can in fact have them there. And so this year, we felt very honored that we had accomplished our goal with 6 pilots. We were honored in May of this year by the Boston Globe as one of the most innovative programs. And I'm not so sure this is innovative, because I believe that innovation is not our problem. There's a lot of innovation going on. It's integration. What we have done is simply brought together the best among the best and integrated it. 6 pilots have been launched. We had another great honor, American Online. I'd like to give them acknowledgement here today. American Online does not at all provide cash donations. What they do is that they provide a cause of the day marketing opportunity by being listed on their front page. And Healthy Villages in October was the cause for the day, with thousands and thousands of hits and people really stepping up and really asking, what can we do to be part of this program? Next slide, please. Let me know when I'm done. This will be my last slide. These are the 6, some of the pilots that are going on. I mentioned the Angels of Hope. In Luwala, we have hooked up with Oakstone Publishing here in the U.S. that is making available CME on our devices. So now the students have an opportunity, or the clinicians have an opportunity to have the availability of current, up-to-date education. In Shanghai, we have partnered with Project Hope. As you know, a number of years ago, there was a devastating earthquake in this area, and many of the medical residents and hospitals, emergency rooms, lost a lot of their technology opportunities in terms of reaching patients. And so we are now providing the mobile devices. They're preloaded. By the way, that's the key. We preload it to what those communities want. In Louisiana, for example, with the Gulf oil spill, there has been a score of new diseases, skin diseases that are surfacing. And so their need with us has been to preload it with skin dermatological information that can help us better treat. And we have on my commercial side the proprietary linkage that you put the word in and it will bring all the information together and load it in a way that can be easily read by the clinician.
Donato, I'm sorry.
Please.
So, no, perfect. Bringing up Louisiana, that gives a great segue. I know you have a pilot in New Orleans, I believe, and HIMSS is headed there for our annual conference in March. This is fascinating on the global scale, but it also should be interesting for the audience to hear what you're doing in the States.
Well, your ears may have been ringing the other day. The RFK laureate, Steve Rattleberry, he is just settled, to his credit, Merle, I think I'm correct, $100 million settlement with BP? $100 million settlement with BP to open up healthcare centers. The first will be named after Robert F. Kennedy, which we are all honored, and we are working with Steve to provide these devices, which we said the other night at the event, we need to get the information for what you guys will obviously want to hear back forthcoming in the spring. So we feel there's a great opportunity to really demonstrate. Let me just get to one last slide I'm going to leave, the data. I just want to show them the data. Because at the end of the day, you know, it's like I always tell my staff, when you see the sign, 3 billion people visited McDonald's, it doesn't mean anything to me. How many people ate there? I want to know the tangibles. The same thing here. It's not just important in terms of people have devices. Look at the astonishing. How often do you use the devices? And you can just see the graph here. We have a significant traction around engagement, which, by the way, I'm disappointed here in the U.S. when we look at this data. It's not as, revealing as what we see here. The clinicians are using it. What they need is training, and so we are staying with them. We are on either Skype or telephone calls, if not every week, at least every other week, helping them. They help us. For example, we had one community where they don't have power. And so what we did is we hooked up with a organization, again, I forget the name, but we hooked up with an organization that has solar panel the size of a CD case that's only for mobile phones. And so we brought those into the community, and they're using them, and so they're charging the device. In Haiti, we have a challenge right now, and I'm only saying this because if anybody can help me with this, please step forward. They would like to have the content translated in French. And so we're working to develop a grant. So if anybody can help me there, that would be very helpful. Thank you very, very much. And thanks to the panelists. It's great to see what you all are doing. I hope that this gave you a little bit of food for thought around how we really are making a difference together. Thank you.
Thank you, sir. Now we have the opportunity for about 10 minutes of Q&A. The panelists are here to answer back and forth and give different perspectives on the overall way they've embraced different mHealth strategies for clinical intelligence and the overall industry perspective on that. We've heard quite a variety of perspectives this morning, and I'd like to just circle back to Yale with one question I had. In terms of how, the text program itself and the outreach is phenomenal. Two questions. One, can they reply to the text? And secondly, how are you measuring the success?
So this program's actually not out there. So what I'm saying is that we would like to make it out there. One of the things that happened when there's been a lot of effort in the federal government about what is the role in mobile health. And there was a work group that now the White House Chief Technology Officer, he was the HHS Chief Technology Officer just a couple of years ago, put together, and he had a bunch of advisors. And I think what we really came up with is that there needs to be a strong role for the federal government, but it needs to be one of innovation and then stepping back and letting the creativity out there happen, and then possibly coming in and doing an evaluation so it's not biased. So as far as these programs, I'd love to see more programs happen, but I'd like to see less federal involvement because we slow things down, as my colleague, whoever is in the audience. So what we'd like to do is get these messages out there, but rather than just stick them on a website and no one knows about them, figure out what are the opportunities within the private sector to leverage this. So not going with just one company, but how do we make this broadly available so that many people can innovate and do creative things with it. As far as your response to texting back, that's one of the features that could be done. So Text for Baby is very simplistic, and I've known people to criticize Text for Baby. It's simplistic for a reason. When the program came out, smartphones were not ubiquitous. And when you're talking about the population we were trying to serve, they didn't have smartphones. So just sending them a one-way text message was the ideal way. We got agreement from across the industry. It looks like everyone's American in the audience. If I'm mistaken, I'm wrong. America is so bound. No other nation has this limit on paying per text message. We have limited minutes. We have all these guidelines and regulations. So, we need to figure out how do we get messages if people don't have unlimited text messaging plans. Because it costs the money not just to download the app, but then it costs the money per text message. So Text for Baby, it was a phenomenal idea to negotiate so that there were unlimited text. It's not unlimited. Anything related to Text for Baby was not counted against their texts and their messages. And that's been phenomenal. The program has evolved to suddenly be a link to other resources. There is now a survey that goes on with Text for Baby so people can answer questions and feedback. But initially it was just a one-way, the only bidirectional was you texted in and you gave your baby's birth date so we could personalize. With this program, we could go further. Smartphones are getting more ubiquitous. We can link to other resources. The messages link to, for example, Medicaid and state children's health programs. There's messages that link to other resources for the parents. We'd love to see a even more widespread linking to websites, linking to URLs, linking to opportunities. As we move forward, linking to actually doctor's offices, identifying your nearest doctor's office with existing apps that are out there, and making an online appointment, for example. So really, the world is, the oyster is open on how this could be used. All we've developed is the bare basis, and we would love to see it become more than just this. And that, again, the role of the government really should be not this creativity. It should just be starting the concept of what we need, identifying that need, and then letting you guys innovate and create.
Along those lines, Healthy Villages, do you see potential to take a program such as what HRSA's developed and expand it globally?
Because we're out of time, quick answer, yes.
Please, go ahead.
Okay, this question is for James. Mike, this question is really just a question from my parent who has heart problems but doesn't live in Arkansas. Besides looking at your program as a way to reduce cost, have you also looked at it as a chance to increase revenues by sharing that program with other payers, helping them implement it and kind of roll it out?
And I think that's a good question. We could always move to Arkansas. It's really nice. And that plug for the natural state aside, one of the things that Arkansas Blue Cross wanted to do, and the reason they spun this off in a separate organization, was they want to offer it nationally. It is that's the goal. And there's nothing that says these pods and the technology can't be used anywhere, and I would guess even internationally. And the nurse practitioners. It's just the building the relationship with the physician's office. So, yeah, they'd be happy to do that, and it could be deployed elsewhere. That's the goal. Well, this specific program was tied to private insurers or private payers or purchased health care, not public health care. So, absolutely, yeah.
Great. We'd like to thank the panelists this morning. I think we've heard a lot of very valuable information.